is Rory Spiegel and Ryan Radecki, and this is the Annals of Emergency Medicine podcast. It is April 2025. Ryan, how goes it?
Splendid.
Yeah.
Better than ever.
Great. Well, we've got a good month. Why don't we get right in? I think you're going first.
A short month. Only a couple articles in this that have trickled through into April to talk about. And the first one I'll talk about here is called Trends in Firearm Injuries Treated in Emergency Departments by Individual and County Level Characteristics, 2019 to 2023. The lead author here is Marissa Zwald, and they are were with the CDC's National Center for Injury Prevention and Control. This is a very simple study answering the question, how has the rate of gun violence changed over the past few years? And who is it affecting the most? The answer is already partly known. ED visits for victims of gun violence jumped up from 2019 levels by around 30% using national surveillance data. And while it has drifted down over the past few years, it still remains elevated over the 2019 baseline. Augmenting these data, however, is the Firearm Injury Surveillance Through Emergency Rooms, the FASTER program, launched in 2020, which gives further real-time data on injuries at the state and local level. And this study collects data from EDs in the first 10 jurisdictions funded by this program, 650 counties in District of Columbia, Florida, Georgia, New Mexico, North Carolina, Oregon, Utah, Virginia, Washington, and West Virginia. These data are broadly consistent with what is already known at a national level. Firearm victims are not evenly distributed across the U.S., with Oregon and, interestingly, West Virginia reporting the lowest rates of firearm victims, and Washington, D.C. and New Mexico the highest. Then, as generally expected, the victims of firearm injury are those with the highest social vulnerability index scores, with those in unstable housing, racial and ethnic minorities, and of low socioeconomic status disproportionately affected. There's a fair bit of data to tinker with, as well as some useful links to dashboards included in the manuscript itself. And, well, hopefully you enjoyed hearing about this useful work, as these programs are zeroed out for funding in the new Health and Human Services budget for the next fiscal year, and I would be surprised if most of these authors weren't already on administrative leave. In theory, data like this might help target programs to prevent firearm injury, or to support the survivors of firearm injury, but that won't be a priority for the U.S. moving forward, obviously. Indeed, one of the links in the accompanying editorial by Lois Lee already lands on a dead site, and it is clear her hopeful musings on the future of real-time surveillance and injury detection are not going to come to fruition.
Yeah, I mean, you can see how, if this data was truly live, you could use it to kind of track policy changes and how that affected outcomes, so on and so forth. But done like this, it is like a snapshot of the past. And usually by the time it's published and we see it, it's, a year or two past where it was. And so it's hard to really make active decisions off it. So having a live database would be far more interesting, though, as you said, that might not be a possibility in the near future.
Well, one can hope that some of these programs are just mothballed as opposed to deleted entirely, and some of them can have the tarp pulled off of them in a few years if the environment changes. But for now, this is what could have been as opposed to what might be.
Yeah, or even like the website's taken down, but it's still collecting data under the hood, and you just kind of plug it back. You kind of plug it back in when things change, and you get all that data that was actually happening.
It's an uncertain time.
Yeah, indeed. All right. Well, on that happy note, let's move on to our next article. Our next article is midazolam and ketamine for convulsive status epilepticus in the out-of-hospital.
Two happy drugs.
Yeah. And the lead author here is David Farsi. And, I think we're all fairly comfortable with the use of midazolam as a frontline agent in the treatment of status. But ketamine, as is with ketamine, has been suggested as a treatment of status as well. And though the data supporting its use is somewhat lacking, these authors basically report on a protocol that they instituted pre-hospitally in their ENS system, where they used ketamine as a secondary agent for patients who had status refractory to the initial dose of midazolam. Essentially, the protocol that was in place prior to the initiation of this protocol in 2017 was to give adult patients midazolam at 2.5 milligrams IV or 5 milligrams IM when they were in status. And then they could give an additional dose of the same amount if the patient was still seizing after 5 minutes. So right off the bat, this is actually fairly low doses of midazolam. If you look back at the Rampart trial, which is kind of our randomized control trial showing the efficacy of midazolam, they gave 10 milligrams up front IM. And so obviously here we're somewhat underdosing our patients, which is important to know as we look forward. When they changed their protocol to include ketamine, they they increased the midazolam dosing slightly to 5 milligrams IV or IM. So again, better than before, but still underdosing. And then after 5 minutes, patients could receive 100 milligrams of IV ketamine or IM ketamine if an IV wasn't available. And they essentially conducted a retrospective cohort study looking at outcomes of patients in this pre-hospital system. And they compared patients who received 2 doses of midazolam, patients who received 1 dose of midazolam followed by a dose of ketamine. Obviously trying to control for the patients who stop seizing with 1 dose of one medication, right? And so the idea was if you're going to get ketamine, it means you probably had already gotten midazolam. So let's look at the same sort of patients in the previous cohort, the ones who got midazolam and then received a second dose because they were still seizing. While this is kind of like a pre-post protocol initiation, they really didn't look at it that way. Basically, they selected patients just simply if they got 2 doses of midazolam or 1 dose of midazolam followed by 1 dose of ketamine. And they enrolled patients from August 2015 to 2024. Overall, there were 690 patients that met their inclusion criteria of receiving 2 doses of midazolam or a dose of midazolam and ketamine, and they included 688 of them in their final analysis. 80% of the patients who received 2 doses of midazolam have stopped seizing after that second dose. And this was compared to 94% of the patients who received 1 dose of midazolam followed by a dose of midazolam. Now, these groups are widely different, meaning there was 598 patients who received 2 doses of midazolam and only 90 patients who received midazolam followed by ketamine. They did a propensity score, which brought the whole cohort down to 89 patients in each group. And even after the propensity scoring, the ketamine group seemed to perform better. Again, 82% of the patients who received 2 doses of midazolam had their seizures stopped versus 94.4% of those who received midazolam and ketamine. So obviously, this study is fairly limited by its retrospective design. Most specifically, it's really hard to control for the multiple confounders that can determine why patients got 2 doses of midazolam versus those who got 1 dose of midazolam followed by ketamine. Are we really looking at the same patients? In addition, as I said before, the midazolam doses seemed fairly low, both pre and post ketamine implementation, meaning you weren't really actually getting a full therapeutic dose of this medicine in either case. And I would also say that the ketamine doses seemed really low. If you look at like the guidelines, now the data on ketamine and status is actually fairly limited. But if you look at the guidelines, they recommend at least 1.5 milligrams per kilogram loading dose with a max load of 4.5 milligrams per kilogram. Basically, you're giving 1.5 every 5 minutes until the seizure stops. So 100 milligrams, unless you have a fairly small person, isn't even coming close to that loading dose. It's really hard to know exactly what to do with this data other than it's an interesting idea. I think we certainly need way more information before we treat ketamine as a valid tool to stop seizures, especially in the pre-hospital setting.
Well, you're a little late because I think this system in Florida has already decided it's a valid tool to treat seizures because they've added to their protocol in 2017, which is fine. I just wish they had done a real, true controlled comparison. EMS systems are ripe for cluster randomization. Put it in some trucks, compare it to other trucks that don't have it, roll out the protocol and stepped wedge, a real rigorous pre-post design. There's different ways they could have done this to give us better data, but now the call is out for somebody else to do this and give us better data about its true role and about the adverse effects potentially. Because obviously giving somebody, multiple doses of intramuscular intravenous midazolam does a thing to their airway protection that sometimes gets them in trouble in the emergency department. But ketamine might spare some of that, but ketamine has its own side effects too. So we just need that little bit of better data.
Yeah, I mean, I think the big issue here is like severely underdosing your patients in status and not getting control of their seizures, right?
With both of them, actually, which is interesting.
Yeah, right. And in this cohort, everyone seemed to stop seizing anyway, but most seizures stop on their own. So without like a randomized control design, it's really hard to know how harmful the underdosing of their medications were.
So we'll call this the placebo arm, and then we'll do a trial with real ones. All right, we'll move on to what's going to be our last article to discuss from this issue. It's called Effectiveness and Safety of Pharmacologic Therapies for Migraine in the Emergency Department, a Systematic Review and Bayesian Network Meta-Analysis. Our lead author is Ian D'Souza, and they are at SUNY Downstate. And it's pretty clear the new sexy thing is the network meta-analysis. There must have been a series of software updates to the statistical packages commonly used to support systematic reviews, because publication of network meta-analyses has exploded faster than firearm injury over the past few years. Today's topic is headache in the emergency department, and specifically, these authors included intravenous or intramuscular administration of metoclopramide, sumatriptan, valproate, caffeine, ketorolac, paracetamol, lidocaine, dexketoprofen, chlorpromazine, dihydroergotamine, prochlorperazine, meperidine, hydromorphone, propofol, dexamethasone, and ibuprofen. They also included greater occipital nerve blocks where outcomes permitted. With all these different agents, the authors were able to identify 64 studies, not all of which addressed each outcome. Adequate pain relief at 2 hours, change in pain intensity at 1 hour, or the need for rescue drug at 2 hours, and significant adverse reactions. Approximately each of these comparisons included a subset of 20-odd trials and about 2,500 patients in their network configurations, with the most frequently studied medication being metoclopramide and metoclopramide combined with diphenhydramine. Most nodes in the network had fewer than 200 patients, and many had fewer than 100. With all these comparisons and data to wade through, it's safe to say the best place to get the complete rundown is to go to the article itself. However, the authors do try to crown a winner. Using Bayesian likelihood and the ranking ability of network meta-analyses, they find, with low certainty, chlorpromazine, prochlorperazine, and metoclopramide combinations may be the most effective options, while placebo, valproate, and ibuprofen are definitely the least effective. With, and this shows the weakness of indirect comparisons, ibuprofen being less effective than placebo in some rankings. Propofol likely demonstrated the greatest adverse effect side profile, and then along with, unfortunately, most of the other effective options, your chlorpromazines and your metoclopramides also had an increased incidence of adverse effects. So a lot of imprecision and noise here, but little to refute use of what are likely the most common agents already in use in your practice. Obviously, we'll take this opportunity to remind everyone not to use opiates. But the biggest problem with this review, where is droperidol?
I was about to say, that was going to be my one comment.
There's your one comment. Deep in the supplement, you can find the authors state that droperidol node would have been too small to include, along with haloperidol, octreotide, and ketamine. I mean, I've seen olanzapine, but I don't know where octreotide came from. And that issue goes back to their search strategy, which does not seem to have swept up all of the trials involving droperidol for various reasons. Some are intramuscular, some are outside the emergency department, et cetera, et cetera. So this goes back to the limitations of network meta-analyses, in which to have that transitivity required to make both indirect and direct comparisons, the systematic review really needs to be aggressive at pruning the evidence base to generate the most homogeneous set of trials, which introduces, as you can see here, potentially significant limitations.
I mean, my largest issue was the lack of droperidol, which is obviously one of the better drugs to treat migraines with. But also, I think, despite the level of certainty on this, I think we obviously had all of this data prior because this was a meta-analysis of previous data. And I think we knew that these were the best, most effective initial drugs to treat migraines with. So it's nice that it already confirms my biases.
Yeah, I mean, these are all studies that have been out there, but we've always traditionally looked at them as their direct comparisons, metoclopramide versus X, metoclopramide versus blah, and as opposed to trying to do what network and meta-analyses do, which is allow for all these indirect comparisons so that you can rank them against each other, which is the quote-unquote novelty here. But it all just boils back down to the core data that you've included. And there it is. The same agents that we think are effective are the same agents that bubble up to the surface. And we all know propofol is going to have the worst side effect profile.
I remember a few years ago, it was like 2015 or 16, where there was like a small rate of use propofol for your migraines. And
there was a big deal. It was like, we're going to fix these people.
I always thought, well, one, for the most part, migraines are pretty easy to fix. And two, it seemed like not the wisest of all decisions. But yeah, I think this is pretty standard that compazine and metoclopramide are your two most effective agents. And I've always thought valproate doesn't really do much, which, it appears it doesn't. There's been a number of studies showing, all your additional cocktails that you add to either metoclopramide or compazine don't really add much to them. And they're really the core of your treatments. And then druperidol, despite not being in the study, there is data showing that it's fairly effective, especially as a second agent when the first two fail.
Down here, we were a thorazine shop, a chlorpromazine shop, until droperidol came back into the ED, and now pretty much swung all the way over to droperidol.
I've basically just go to droperidol first at this point because it's so effective. And
I suspect actually it was probably part of me coming in 5 years ago that increased the popularity of the use of droperidol in our department.
Really, it's kind of ironic because I guess Australia and New Zealand were like the last bastions of droperidol use for so many years.
They use it for sedation a ton. It was like their first line agent versus haloperidol for a long time. But for whatever reason, it just wasn't in our emergency department specifically. It was in the Pyxis, like up in the PACU for like post-operative nausea and vomiting and things like that. We just didn't have it in our department until a couple of years after I started. I'm like, hey, let's use this all the time. And they're like, yes. And they're like, abdominal pain. Oh yes, droperidol. It's like she doesn't feel like she can get up and walk. Droperidol.
Wow, look at you changing worlds, gunslinging American coming over and adding droperidol to everything. Well, we covered ketamine. We managed to fit droperidol in, even though it wasn't in the study. We didn't get machine learning in this month, which is disappointing.
There was very little informatics this month. We'll have to wait for another month to do that.
We'll just have to add an extra one to the next month to make up for it.
Well, yes. But of course, we could talk about, if you would like Rory and I to be replaced with artificial intelligence, that technology does exist. There are podcasts that will automatically generated AI podcasts if you'd rather listen to a robot than us. So we would understand.
It'd probably be a lot funnier. Well, on that note, any comments, questions, or concerns, or requests to replace us with AI, you can email annalsaudio@acep.org. Otherwise, until next month, this was Rory Spiegel and Ryan Radecki, and this was the Annals of Emergency Medicine podcast.